And so in summary, and I can't emphasize this enough, what you need to do is to make sure you monitor the patient. We're going to go over a few things that are very important with regard to monitoring. Secondly is we need to be aware of the patient's medications, and that includes any over-the-counter supplements or over-the-counter drugs that they're taking. One of the things that I always tell my students and always tell a number of other people is that we want to encourage the use of a single pharmacy for filling the prescriptions. This will help as a monitoring of drug interactions. And be aware that problems with the patient tend to occur more frequently when their pathology changes. This may mean their disease may progress, sometimes may even get a little bit better. This may mean when other comorbid diseases may arise. These are when we tend to have problems. Anytime there is a change in medication, and that includes both increasing or decreasing medication, or adding a medication, taking a medication away, and then when there's a dosage change. Also in this mix, we like to also consider the fact that what can occur is that changing from a name to a generic, or even between different generics, can create a problem. So with that being said, let's move into reviewing some of the issues about laboratory monitoring, and I'm going to go through these slides fairly quickly and hit the high points. Looking at electrolytes, sodium is one of those electrolytes that we would monitor. The sodium level can reflect an imbalance between sodium and water. So for example, if a person is hyponatremic, which would mean a low sodium, this would mean that they either have a decreased amount of sodium, either total or intravascular sodium, or it could also be indicative of that the individual has an increased free water level, which basically dilutes the sodium out. So one of the conditions that may produce hyponatremia would be a situation where is what we call water toxicity. We see this sometimes with individuals that have abused ecstasy, where they drink a lot of water, a lot of fluids, and basically end up washing the sodium out. It depletes their sodium, they become hyponatremic, and as a result of that may set up for convulsions and seizures. The opposite of this is hypernatremia, and what that can mean is either they've had an accumulation of sodium so that their blood sodium is elevated, or what it can mean is that the individual has become usually dehydrated. And hypernatremia is not an uncommon thing that we might see in an elderly patient who just doesn't drink, or if someone is depressed or has some other psychiatric issue going on, they may not drink as well as not eating. So sodium levels, we look for hyponatremia, hypernatremia. Potassium is particularly on slide 20. We are particularly concerned about potassium. If I had to worry about an electrolyte, potassium would be the one I would worry about. Generally, the problem with potassium, if it goes up or down, it can produce severe arrhythmias. So if you develop, and remember potassium levels potassium is referred to as kalemia, so a hypokalemia, that's K-A-L-E-M-I-A, would be a low potassium, and a person may develop severe arrhythmias. And a hyperkalemia would be due to an elevated potassium, and that can also produce severe arrhythmias. Most potassium abnormalities are going to be probably associated with alteration in renal function or GI function, in other words, a lot of vomiting or possibly a lot of urination that may occur. So that's skin losses. We can get potassium if a person has burns. But we also see alterations in insulin or aldosterone, or even acid-base balance can alter potassium levels. Aldosterone is going to increase the secretion of potassium into the urine, and so we can develop a hypokalemia as a result of excessive aldosterone actions. We talked a little bit about in pathophysiology about acid-base balance, and what we see is that when a person develops a metabolic acidosis, that produces hyperkalemia. It basically will move hydrogen into the cells and swaps that for potassium. On the other hand, the metabolic alkalosis moves the hydrogen out of the cells, swapping it for potassium, and we develop a hypokalemia. Insulin tends to drive the potassium into the cells. Probably slide 22 is your best slide to think of for summarizing the potassium. Hypokalemia, one of the concerns that we will see is a person that's taking diuretics, for example, for heart disease, are subject to develop hypokalemia. Another group of patients that may be specifically subject to hypokalemia would be individuals that may be abusing diuretics, such as individuals with eating disorders. Anytime an individual may undergo a lot of diarrhea or vomiting, we can develop hypokalemia. And then we also have hyperaldosteronism, which is an endocrine disorder which can produce this. Occasionally, if we've got a hospitalized patient, we may see some, if they're getting a lot of potassium-free IV fluids, they can develop that. Generally, the hyperkalemia we're going to see primarily in patients with renal failure, where their kidneys cannot get rid of the the excess potassium. But also in people that develop renal failure, we can see some loss of potassium there also. So let's go to slide 23, and that moves us to renal function. Very important assessment that we want to monitor for a lot of drugs, especially in the elderly or patients that may have some sort of renal disease. One of the common drugs, or excuse me, not drugs, one of the common tests that we use is to measure BUN, which is the BUN, or the blood urea nitrogen. What that is doing is it's actually measuring the concentration of nitrogen or urea that's actually in the serum. And it gives us an idea of if the person is hydrated, and it gives us an indirect assessment of renal function. Blood urea nitrogen is an indirect measurement. The idea is that normally we will not accumulate urea in our blood, or nitrogenous products in our blood. We should get rid of them through the kidneys. So if we see these BUNs going up, this would suggest strongly that we have a problem where the kidney's not getting rid of it. One of the problems with blood urea nitrogen is it can be affected by protein levels where the body is basically altering its protein. This can be with diets, with some parenteral feeding. So again, keep in mind that the blood urea nitrogen, the BUN level, is a good quick assessment, but it is subject to influences by a number of things. Another indirect measurement of renal function is to measure blood creatinine. Creatinine is actually a byproduct of creatine and creatinine phosphate metabolism that occurs in the primarily in the muscle. And the idea is normally the creatinine is going to be excreted by the kidneys. So if we see creatinine levels going up, this could mean that our kidneys are not functioning. But again, just like the BUN levels, the creatinine is subject to, for example, hydration status, whether muscle tissue is being broken down. But on a lot of laboratory-based basic metabolic panels, we will see BUN and creatinine normally run as our first index or as our first assessment of renal function. And again, keep in mind these are indirect. We use them, but they are subject to problems with interpretation sometimes. And this sort of follows up that if we see a reduction in serum creatinine levels, sometimes that can occur where we have some muscle wasting away. Our biggest concern usually is going to be if our creatinine levels are going up, which would suggest that there is a renal dysfunction. We're going to actually, on slide 26 here, the gold standard for determining renal function is actually creatinine clearance. Okay, it's considered the one of the best or most accurate assessments or approximations of glomerular filtration rate, which is also known as GFR. So we use the creatinine clearance to assess renal function. Sometimes we will determine renal function, and we may adjust dosages based upon these. And we also will use creatinine clearance if we're giving a patient a nephrotoxic drug. We can monitor renal function with that. Now, creatinine clearance is a little bit more refined than just blood creatinine. And if you go to the next slide, I'm not asking you to memorize this slide, but here's the formula. And creatinine clearance basically the way we determine it is we're going to measure creatinine in a 24-hour urine sample. We're going to get the urine volume over that 24 hours so we can normalize it. We're going to measure plasma creatinine, and then we figure this over a period of 24 hours. So if you notice this formula, one of the key points here is that we're looking at both plasma and urine. So the advantage of creatinine clearance is we're measuring blood and urine, so that is measuring either side of the kidney. Whereas creatinine levels alone are only looking at the blood. But creatinine clearance is considered the gold standard for measuring or determining renal function. Now, some other things that we're just going to go through pretty quick is you may not be involved with doing urinalysis, but urinalysis may give you some information that is helpful. What we would hope to see in a urinalysis is basically there's no cells there. We're hoping your kidneys are not sloughing cells in there. We hope that there's no microorganisms growing there, which may be indicative of a urinary tract infection. And we don't want to see any red blood cells. Red blood cells would potentially suggest that there may be things such as kidney stones, tumors, or some sort of damage to the glomerulus or the kidney itself. If we see red blood cells or microorganisms or stuff, that could be indicative of renal dysfunction. On slide 29, just a few things for you to be aware of. Hematuria is the pink or red urine, usually associated with red blood cells in the urine. There are a few drugs that may turn the urine different colors. Pyridazole is a drug used to treat urinary tract infections, tends to turn the urine red. That's just the color of the pyridazole. We don't want white blood cells there. If we see white blood cells to any significant level, that's referred to as a pyuria, which suggests that it is that you may have an infection there. And then if there's reports of cast, these can be cellular or hyaline or granular. These are associated with, these are sort of the remnants of cells that have been left and would be indicative of renal dysfunction or renal damage. Slide 30 is one that you should be aware of is if there's protein in the urine. Generally, if protein is, there should be no protein in your urine because it's a large molecule. And if you're getting protein in the urine, that would suggest that your kidneys are leaking and would suggest severe renal dysfunction. And the more or the higher degree of proteinuria, the greater the kidney dysfunction. So occasionally you can get a little bit of proteinuria associated with things like fever, stress, or severe exercise that's going to last a few days. But generally, unless there's some predisposing factor, we hope there's no protein in your urine. That would have a significance of saying we may have either renal problems or renal failure occurring or renal damage. And it would also have an impact if we had drugs that were protein bound because the protein levels would be decreasing, and that would be significant and could affect, come into play with affecting the amount of drug dosage that we would use, or whether we might even want to use a drug that's protein bound. Slide 31, a couple of other things we look at. Specific gravity. Those of you that are doing any drug testing, we look at specific gravity in urinalysis to determine if the person has tried to dilute out their urine. What specific gravity is, it's pretty much measuring the ability of the kidneys to basically concentrate urine. And so the idea here is to, probably the biggest use we see for it right now is an evaluation to see if people are trying to dilute out their urine to pass a drug test. There may be bilirubin. If that shows up in the urine, that could suggest either some internal bleeding or potentially liver disease. If there's a lot of bilirubin in the urine, what you're going to see is the urine tends to be brown and foamy. And then another one that would be important to you would be glucose and ketones. They would be indicative of diabetes. And the reason this is particularly important is because some of the drugs that you might prescribe may produce diabetic states, such as the antipsychotics. Let's just touch very quickly on cardiovascular lab tests. What we look at is things like creatinine kinase. It's also referred to as a CPK, which is creatinine phosphokinase. This is primarily in skeletal muscle, but it can also be in brain and heart tissue. What we worry about is if your CK levels go up, it may be indicative of a heart attack. We also see that if there's extreme muscle contraction or trauma to the muscles, it can go up. And some drugs that may produce things like neuroleptic malignant syndrome may result in CK levels going up. Slide 33, the other test that we see used, well, total CK, what we primarily look for is called CK-1b, stands for muscle and brain, and that is the one we look for to see if there is primarily any damage to the heart. If we're thinking it's a muscle problem, skeletal muscle, we may look at CK-MM. Lactate dehydrogenase has been used. We see that for testing for myocardial infarction. So it's one of those enzymes that can be looked at. And again, you're seeing I'm going through some of these pretty quickly because you're not going to be dealing with them a whole lot, but you need to be at least aware of them. Another test that we've looked at for these cardiovascular lab tests is troponins. And basically these are the ones that really give us an index on myocardial cell injury. And again, these would be ordered by a cardiologist. You would not be ordering these, but if your patient had elevated troponins, CKs, things like that, it may be indicative that you may be having some heart problems with your patient. There's two, we call them lab tests, but basically they're assessments. The ECG, electrocardiogram, we're going to use to assess the rhythm. Doesn't give us an idea of how well the heart contracts, but it does give us an idea if there's any arrhythmias. It'll give us rate and rhythm. And we will use that because a number of the drugs that you prescribe will affect or can affect cardiovascular function. And another thing which we're starting to use quite a bit is echocardiography. And we're using this for some pre-screens, especially on drugs that may affect the heart. We're starting to see more echocardiography being done on patients that are put on stimulants, for example, to make sure that there's no abnormality in the heart. You can get a lot of information from these echoes, and it would be something that potentially you might refer to a cardiologist to look at. Liver test. These are very important. So a few of these that you should be aware of. Albumin is a main protein. Liver basically synthesizes this. So what we want to do is determine if albumin levels are there. Also, keep in mind that a lot of drugs will bind to albumin. So if we have low albumin levels, it can be indicative of liver problems. It also, as indicated on slide 36 here, that it may increase the free level of drugs, because if there's less albumin and they're highly protein bound, there's less chance of them binding the drugs. Slide 37 is we do look at clotting times. Prothrombin time is a measure of blood coagulation. That would be a concern if their prothrombin time was prolonged. This would be indicative of potentially liver disease. It also may be indicative that they're on an anticoagulant such as warfarin, which is something you would want to be careful about if you have a patient on warfarin because of the potential for serious bleeds that occurs. Just a few more liver tests that we're going to touch on. Alkaline phosphatase. This is looked for to see if there's any problems with liver or bone. 5' nucleotidase may be indicative of liver disease. So again, these two are indicative of liver disease. Be a way to function these. Gamma glutamyl transpeptidase, which is GT, also used to assess liver disease. But you can see on some of these slides that they affect other tissues. Slide 40 is a very important slide for you. You should know this. One of the common liver tests that we run when we do a basic metabolism is aspartate aminotransferase, AST. Used to be called SGOT in the literature. If there is liver disease, this is one that goes up. So it is one that's very commonly run. So make sure you're aware of that AST is used to monitor liver function. We have another important liver test, which is called ALT, which is alanine aminotransferase, and it used to be called SGPT, and if it's elevated, it usually is indicative of liver disease. Lactic dehydrogenase, Another enzyme that is indicative of liver disease, there's a specific isozyme which is specific for liver disease, but again, all of these are specific for or indicative of liver disease, so things that we want to monitor. Importantly, the two that's usually monitored first is ALT and AST, so keep that in your mind. Total bilirubin is if it goes up, that would suggest that there's liver disease. Can also be suggestive of some breakdown of blood elements and biliary obstruction. Keep wanting to say constriction. So total bilirubin, if that goes up, that is basically going to be indicative of liver disease. And if the total bilirubin goes up, one of the things that we often see is the development of jaundice. One of the things, if we do have a person on slide 43, if we have a person that is specifically having liver problems, their liver seems to be failing, or there's having elevated ASTs, one of the things we may monitor for is ammonia. Serum ammonia basically can build up if the liver can't metabolize it, and it can build up to high enough levels to produce what is called hepatic encephalopathy or even coma. So this is a very important thing. We see it also occurs, it's elevated in Reye's syndrome. Can go up when people are taking a lot of protein in their diet. Valproic acid, Depakote, can elevate it. But generally, elevated ammonia in the blood is considered to be indicative of some problem with the liver and may have severe consequences associated with for example, producing encephalopathy. Thyroid test on slide 44 will be important for you to be aware of. Free T4 actually measures the active T4 levels. In the past, it was difficult to measure free T4, but technology has improved, and it basically is now very routinely ran. If you have low T4s, that's hypothyroidism. High T4s would be hyperthyroidism. And slide 45 is another measurement of thyroid, and this is called the thyroid stimulating hormone. And basically, the little s refers to sensitive TSH, and this is a way to determine whether it's the thyroid gland or if it is some problem with the pituitary axis. So, for example, if you have low TSH, that would suggest that the pituitary is not secreting thyroid hormone or thyroid releasing hormone. If you have high TSH, that means that generally the pituitary gland is secreting excess thyroid. And so by looking at both the TSH levels and the T4s, you can basically find whether it is a thyroid problem or a pituitary problem. Slide 46, diabetes is an important issue. Diabetics are very difficult to treat. What we are going to do is that we have to be careful anytime we're treating these diabetics, but also keep in mind that because some of the drugs you would prescribe can produce this, it's going to be important for you to monitor this. So the things that we look at is probably the best test we want is a fasting blood glucose. Person fasts for 8 hours and then we measure their blood glucose. We often would like to do what is called a 2-hour postprandial blood glucose, and basically after they eat we take a blood, and those results can be put into context with the fasting blood glucose to give us a better feel for that. Another very common thing that we measure is glycolated hemoglobin. It's also referred to as HbA1c, sometimes referred to as A1Cs. Basically, that is determining the amount of glucose incorporated into hemoglobin, and it affects long-term glucose control. That is probably our best index for assessing blood glucose control is basically glycolated hemoglobin.